Hello, good afternoon, everyone. On behalf of Dentium, I warmly welcome you all in today's webinar on precision in limited bone volume, the role of narrow diameter implants. This webinar will be informative and beneficial for those who are planning to start implant practices. And we are privileged to have Dr. Avantika Tripathi, MDS Oral and Maxillofacial Surgery, and Dentium Cable as our esteemed speaker, bringing expert technical knowledge and practical insights on the use of Dentium bright implants. We encourage all the participants to kindly stay until the end of the session to avail webinar special packages and a chance to win the bright fixture in the lucky draw contest. Thank you for joining us. Now over to Dr. Avantika.
Thank you, Mr. Suburu, for the kind introduction. So let's start the webinar. I welcome you all to this webinar on precision in limited bone volume, the role of narrow diameter implants. So as all of you must have seen patients with thin ridges in your practice, and you must have thought that now I need to do bone grafting surgery, I need to split the ridge, I need to do extensive surgical procedure to place an implant in those areas. So this session is meant for that, to explain you the point that even if the bone width, bone diameter is less, still we can place a good diameter implant without doing any additional or doing minimum amount of bone grafting surgery. So now why limited bone volume matters? You must have seen these type of ridges in your practice, and you must have thought of placing an implant also by doing an extensive surgical procedure and then placing an implant. So now whenever we are going to remove the tooth, it is expected that the height will be reduced in 12 months to approx 1.2 mm. The width is reduced within 3 months up to 30%. So that is why it is always recommended, if it is possible, an implant should always be immediately placed, as we are going to preserve the buccolingual as well as mesodistal space of that area. In 12 months, it is expected that the width of the bone is reduced to 50%. And there will be 1 to 2 mm of vertical dimension loss within 12 months. About 50% of horizontal dimension loss if the patient is not getting an implant done within a period of 1 year or 12 months. So the buccolingual loss of bone is usually considered as twice buccal as compared to the lingual bone loss. So the buccal bone compresses as soon as the tooth is extracted. The buccal bone starts compressing, and within 12 months we are expecting 50% of the reduction of the bone volume as in aspect of the buccolingual width. Now what is the clinical consequence of this? We will have insufficient width for the placement of a standard diameter implant. So bone augmentation will be required, which is going to increase the cost of the procedure. It is going to take a long time for the treatment to complete. Suppose if I'm going to place an implant today and in a healthy bone condition, I will be loading it approx after 3 months. Then after bone grafting, my loading time is obviously going to increase because it is going to take more time for the bone to form and for the osseointegration to occur. There will be more surgical morbidity because if the volume is very, very less, there is a chance that we are going to extract a buccal, we are going to extract a cortical bone from the symphysis area or from any other area. We are going to put it as a bone graft. So if that case is there, or if I'm going to extract the autogenous bone, we need a second site for the surgery, which is going to increase the surgical morbidity of the patient. Now, what do we usually do in such cases? We are going to do the GBR, which is most commonly done. We are going to do the block bone grafting, or we are going to expand the ridge by doing the ridge split. So we are going to expand the cortical plates and place 2 implants, pack it with the bone graft, stabilize it with the membrane and sutures. Now, if I say that the philosophy has changed now, the old philosophy was that we have to build the bone first and then we have to place the implant. But now the modern philosophy says that we should preserve the biology. We should choose the implant appropriately. According to the case, what if I choose the implant according to my case? Then I might do not need to do that much extensive surgery which I was doing before. So the goal is to minimally intervene with maximum predictability. So we are going to do minimum amount of surgery which is going to give us maximum amount of results. Now, this is possible with narrow diameter implants. Now, what are these narrow diameter implants? Basically, these are classified into 2 types. First, the implants are classified into 2 types, narrow diameter implants and the standard diameter implants. The narrow diameter implants are usually those types whose diameter is less than 3.5 mm, and the standard diameter implants diameter is usually 3.75 mm or more. So any implant which is diameter is more than 3.75, 4 mm, 4.55, 6, 7 are standard diameter, whereas the diameter, the implants which are available in bright tissue level like 2 mm, 2.5 mm, 3 mm, 3.5 mm, all are narrow diameter implants. So this classification is, I have quoted this classification from this article. If you want, you can go through this article. Now, when should we consider narrow diameter implants? The ideal indications for the narrow diameter implants is mandibular incisors. Yeah. So when should we consider the narrow diameter implants? So the ideal indications for a narrow diameter implant is mandibular incisors, maxillary lateral incisors, or it can be central incisors as well. Congenitally missing teeth, if the patient has missing anteriors or thin healed ridges. If the patient has good healing is good, but the diameter, buccolingual width of the bone is very, very less, that we cannot place a standard diameter implant. Limited mesodistal space, sometimes because of the mesial drifting or because the patient had very, very less amount of mesodistal space in some areas. Because of that, we are unable to place a standard diameter implant. So we can choose a narrow diameter implant for these cases. Medically compromised patients where we do not want to do extensive amount of bone grafting. And elderly patients, again, which because of the medical condition or because of the age, we cannot do large, or we cannot do a very extensive surgery in such patients. Now, what are the advantages of narrow diameter implants? It is less invasive because of the diameter. We do not have to do a extensive surgery. The surgery will be very, very less invasive. There will be reduced in the requirement of doing the guided bone regeneration. So the cost will also be less. The duration will be less because the surgical procedure duration will be less because we are placing the implant and doing less amount of bone grafting. So it is going to take less amount of time also. Faster healing, as less amount of bone graft was used or no bone graft was used in the surgical procedure. So the healing will be very, very fast as compared to a patient with the block bone grafting, ridge expansion surgery, or a GBR patient. So it is widely and it is better accepted by the patient. It is comfortable for the patient and it is going to cause less discomfort post-operatively. But so I'm talking about narrow diameters implants, but you must be thinking, are they strong enough to be used? Will it break? Will it not break into two pieces after placement? Will it be able to take the load in that area properly or not? So, what is our common concern? Narrow implants usually get fractured. Once the patient will start eating, once I'm going to do loading on it, it is going to fracture inside the bone. Now, what is the reality? Reality is that the modern implant design has significantly improved now. So everything depends on the design of the implant, that whether it is going to fracture or not. So the success mainly depends on the implant design, on the material strength. It is going to depend on the surface treatment. It is going to depend on the thread geometry and the occlusal planning, what that we have done. Suppose a patient is a bruxer and I gave a full arch prosthesis over narrow diameter implants. Obviously, it is going to fracture. So the case selection should be proper. If properly selected case narrow diameter implants are placed, then there is no risk of any fracturing of the implant or any failure of the narrow diameter implants. So here comes our tissue level, bright tissue level narrow diameter implant, which is narrow but strong. So it is going to provide excellent joint stability, which means that it is a solid implant. It is not hollow from inside. It is available in thin diameter starting from 2 mm. And because it is a solid implant, it is going to take good amount of load in the anterior region as well as in the posterior region as well. So it is considered that a bright tissue level 3.5 by 9 or 11 implant can be placed in the molar area. It can be compared with the 4.5 implant of Superline or any other conventional implant, as because of the aggressive thread design and because of the structure of this implant, it will be able to take good amount of occlusal load in the molar area also. It has a dome shaped body. If you will see the structure of this implant, it is narrow from the top, wide from the middle portion, and again narrow from the apex. So the broadest portion of this fixture is in the center, which means that it is making a largest contact with the bone in the cancellous area. So the bone to implant contact in the cancellous bone is more, which is going to provide more amount of primary stability in the cancellous bone. As I said that it is narrower from the coronal portion of the fixture, so it is going to preserve the bone from the margins. It is going to help in preventing the crestal bone loss because of the narrow neck of this implant. It has a 20-degree external taper and has an external hex. So 20-degree external taper means the abutment is making in contact with the fixture at an angle of 20 degree. It has a concave neck, and when the abutment is contacting the fixture, it is making a connection of external hexagonal. And the neck of this fixture is concave, which is going to provide better soft tissue attachment. So the contour will be better. The soft tissue will be formed in a very contoured manner. So the diameters which are available in bright tissue level implant are starting from 2, 2.5, 3, 3.5, 4, 4.5 and 5. But as today we are talking about the narrow diameter implants, so today we are concerned about the 2, 2.5 and 3 mm implants. They have a standard platform of 3.8 mm. So all the diameter implants will have a standard platform of 3.8, which has reduced the inventory, reduced the confusion, and has made it very, very simple and easy to use. It has a standard gingival height of 1.5 mm. So managing the soft tissue becomes very, very easy, and doing a case also becomes very simple. So all the diameter implants have a standard platform of 3.8 mm. The drilling sequence for placement of a 2, 2.5 or 3 mm implant is, for placement of a 2 mm implant, we need to drill with the initial drill of 2.5 mm. So how will I place a 2 mm implant? I'm going to do the decortication with a 2 mm implant, and I'm going to place a 2 mm implant. Decortication with a 2.5 mm drill, placement of a 2 mm implant, full drilling till the final depth of the implant with a 2.5 mm drill, and placement of a 2.5 mm implant. Drilling with a 2.5, then 3 mm implant, and then placement of a 3 mm implant. Now, the question is, why tissue level implants? The advantages of tissue level implant is that it is going to provide a platform which is positioned above the bone. So the advantage of this is that it is easy to maintain, it is easy to clean, and there is always in the crystal manipulation. So there will not be any contact with the crystal bone with this implant. We will always see an abutment sort of a structure attached with the fixture over which we are going to tighten the prosthesis. So we are not going to touch the bone as well as soft tissue any day. So it is going to provide better soft tissue management. It is going to provide a simplified prosthetics. As I said, that the platform is standard, it is 3.8 mm. So it is going to provide a simplified prosthetics for all the implant options. The hygiene maintenance is easy as the crown is positioned above the soft tissue level. So it is especially useful in thin ridges because of the availability of narrow diameter sizes, thin diameter sizes. It is very, very easy to place them in the thin ridges. We can use it in the posterior mandibular cases also. A 3.5 can also be placed in the posterior mandibular cases because it is able to, as it is a solid implant, so it is able to take that much amount of load in the molar area also. It is very, very easy and simple to use in the elderly patients. So they are narrow, but they are strong. They have a high compressive strength, so they are not going to fracture any day because of their beautiful dome-shaped design, because of the aggressive thread design, because of more contact in the cancellous bone. They are not going to fracture. So as I mentioned that the abutment is making a contact with the outer surface of the fixture at a degree of 20. They have an aggressive thread design. So now let's discuss the cases one by one. So case 1 is of a patient who has a grossly decayed tutu. In this case, patient's preoperative X-ray was taken and the extraction of tutu was done. After the extraction, so the extraction was done atraumatically. There was no buccal or no labial movement given at the time of extraction. If we are going to give any labial or buccal movement at the time of extraction, there is a high chance of fracturing the labial cortical plate. So whenever we are extracting and doing an immediate implant placement, we should only and only pull the tooth. We should not give any movement. After complete extraction of the tooth, we are going to do the drilling in the socket. So the drilling was done with 2.5 mm drill. After that, I took an X-ray to confirm the position, and then a 3 mm lineament guide drill was done. And after that, I placed an implant of 3 by 11 mm, took a post-operative X-ray. After placement of implant, a comfort cap was placed over it and the site was sutured. So this is the immediate temporary prosthesis of the patient. This is the pre-operative and this is the post-operative. So I gave a immediate Essex retainer to the patient, and after 3 months a jig trial was done and the final prosthesis was delivered to the patient. Another case of a thin diameter in the anterior region. If, as you can see, patient came with a missing 1-1. So as the bone was very less, so I gave a crestal with 2 releasing incisions, 2 vertical releasing incisions. So a trapezoidal flap was raised. After complete reflection of the flap, the bone was assessed and the diameter of the bone was very less. So I plan to place a very thin diameter implant of 2.5 mm. So with a single drill of 2.5 mm, I placed a 2.5 mm implant. After complete insertion of implant, I saw that the buccal cortical bone was I saw a slight crack on the entire wall of the entire surface of the buccal wall. So I planned minimum bone grafting in that area. As you can see that my bone is completely covered with the healthy bone. There is no exposure of any threads of my implant. So I am only placing bone graft to bulk up the labial bone. I'm not trying to cover the labial threads with my bone graft. I'm just bulking up the labial wall. So first I prepared the flap. So I gave periosteal scorings. I increased the surface area of the flap. I checked whether I'll be able to achieve primary closure after putting bone graft and membrane. Then I extracted some bone graft from the third molar region with the help of the harvest drills and bone scrapers. After extracting the bone graft, I placed the autogenous bone graft over the defect site. I also made some decortications in the bone. After complete adaptation of the autogenous bone graft, I packed some xenograft over it. After packing of the xenograft, I placed a membrane and I stabilized the membrane with the help of membrane pins. This is the final X-ray of the patient, and then I achieved a primary closure by suturing. So I reduced the surgical procedure. I didn't do any block bone grafting. I didn't do any extensive GBR surgery. I do minimum amount of GBR, and I placed a 2.5 mm implant, which was exactly fitting inside the bone. So this was the perfect size of implant for this case. So as I mentioned before, that your implant choice should be case dependent. You should choose your implant according to the requirement, according to the case. If the case is asking for a thin diameter implant, for a narrow diameter implant, you should not place a wide diameter and do an extensive surgery. Instead, you place a narrow diameter implant and save lot of bone graft, save patient discomfort, save patient's money, and you can load the implant also early. This was the immediate S6 retainer that I delivered to the patient, and this was the final prosthesis. Case 3 is of a female patient in which 3.1 and 4.1 were ailing. So I removed both the teeth. They had periapical abscess. So I removed both the teeth. I cleaned that area nicely. I measured the space. The measurement of mesiodistal space in this area is important because I need to make sure that the 3.8 diameter platform diameter of my fixture should be able to fit in that space. Sometimes the mesiodistal space is very, very less. In those cases, we should always measure the mesiodistal space. If it is less than 3.8 mm, then we need to create some amount of space because the standard platform diameter is 3.8. If that is not fitting in the mesiodistal space, I will not be able to place my implant in that area. It will be like I will drill, but later while placing the implant, I'll realize that now the space is not there. My implant is not going to fit in that space. So it's better to measure the space beforehand. It should be clear in your mind that the platform diameter of my bright tissue level implant is standard. It is 3.8. So if the platform is like, if the space is allowing placement of a 3.8 diameter platform, I can place this implant. Otherwise, it's a big no. So after extraction of 2 teeth, I cleaned the area nicely. All the granulation tissue was removed. The area was nicely scratched. All the infected tissue was removed and 2 tissue level implants were placed in that area. Now again, my implants are nicely embedded inside the bone. There is no exposure of the threads of any implant, but still I am going to bulk up the labial cortex with the bone graft and I am going to stabilize it with the membrane. So this is just bulking up the labial wall. This is not, I'm not covering these covering the threads of the fixture with the bone graft. My fixture is nicely held inside the bone. It is present between the 2 cortical plates. I am just bulking up the labial bone to prevent any future resorption, to prevent any future exposure of my implant threads. So this is the final prosthesis of my patient. Now, what is the key take-home message after seeing these cases? The key take-home message is that thin ridges does not always require grafting. But if they do, obviously the bone grafting will be lesser as compared to us if you are going to place a standard diameter implant. Sometimes in thin diameter ridges, we can skip bone grafting by placing a narrow diameter implant. And sometimes we have to do little bit of bone grafting like I did just to bulk up the labial cortical plate. Proper case selection is the key. So as I mentioned, if your bone is allowing placement of a wide diameter implant, you go for it. But if your case is not allowing placement of a standard or wide diameter implant, you should choose a narrow diameter implant as it is available now. Earlier, the designs were not that good. The structure was not that good. So there was a risk of fracturing of thin diameter implants. But now, because of the evolving technologies, new inventions are being done. So now it is possible. Now even a thin diameter implant is possible in the molar area also, but cantilever should never be given. Narrow diameter implants are evidence based. So now there are a lot of evidences which are proving that yes, narrow diameter implants can prevent ridge split surgeries, can prevent block bone grafting, can prevent extensive GBRs, and can make your surgery any day easier and simpler. So tissue level design helps in simplifying the prosthetics, as whatever prosthetic procedure is happening is, we can see it, we can visualize it in the oral cavity as everything is happening above the soft tissue level. Now it is not at the it is not at the level of bone. Now it is happening at the level of gums. So the Dentium bright tissue level implants helps in providing a minimally invasive solution. So you should always remember that precision begins with planning. So plan your case wisely and you will be able to complete the surgery with more and more precision. Thank you so much for your patience listening. If you have any questions, you can ask.